Great. I think we're going. Brilliant. So, hi, my name's, as Hilary said, I'm Eimear Daly. So I'm with the Crann Centre, quite a varied role. I'm kind of a nurse background, so I've worked with people with disabilities for nearly 2 decades now at this stage. I suppose the logic behind this topic for pressure care is just, I suppose, that there is such a prevalence of it in the community. So I'll go through the slides. If people want to pop in the questions into the Q&A, and I'll ask them at the end, because maybe hopefully at the end a lot of them will have been answered, so we'll see. So I'll just share a screen there now. We'll get it going. Okay, so just make sure my cursor is working. Oh yeah, there we go. So now, so just an overview of what we'll cover today. So pressure care overview of just, I suppose, the prevalence of pressure ulcers and things like that. Then it'll go on to pressure ulcer classification and just how they develop, so you have an understanding of how they occur in the first place, and just the basics of skin assessment. So before starting, I suppose just these terms are up because it's just to get an understanding of what each one means, to understand some of the terms and the definitions and things that are given. You're not expected to obviously remember any of these, but just to have an idea of what they mean. So pressure basically is where you have bony prominences, so any hard kind of area of bone, so where you have, like, you know, where your buttocks sit on a chair, your hips, your ankles, your knees, any of those bones, like your wrists or anywhere like that, where there's a prominence, it's where it stretches and squeezes the surrounding tissue, and with pressure applied it can cause deformity. Shear then is slightly different, and that's also linked to pressure ulcer development. And basically the easiest way to think of shear is if you have someone sitting upright in a chair and they are against a pillow, say on a bed with their legs outstretched, and suddenly they slide slightly. So their skin will stay where it is, so like your frame stays where it is, but internally your skeleton will move within, and it's that force of the bone, bony prominences moving forward. So like where your hips would move forward or your pelvis would move forward, your skin stays in place, and then that stretch can cause kind of a deformation of the soft tissue. Friction then is just slightly different. It's just when two surfaces rub together. So what is a pressure ulcer? A pressure ulcer is defined as an area of localized injury to the skin and or the underlying tissue, usually overlay bone and prominence, and as a result of pressure or pressure with shear. So not from friction. So the friction was just in there just to kind of, suppose that you're aware of the difference of them. So basically it's just injury to your skin, generally overlay bony prominence, and as a result of pressure or pressure with shear. So that's just what it is. So in Ireland, there's about 9 published studies around pressure ulcer prevalence. There's an awful lot more work being done on an ongoing basis, really. There's an awful lot of budgets and money being put into this across Ireland and in the UK and the NHS, just because of the whole prevalence of it, and also the huge cost. So a mean prevalence of pressure ulcers is about 15% of the general population, but there's a huge variation, and in some studies it can be as low as 4%, and for some it's up as high as 37%. So it's kind of an average of about 15% of the population tend to get them. The lowest prevalence of the 4% is seen in the community setting, and the highest is 37% is seen in those in people with spinal cord injuries. So you can see why that's relevant to the services you're attending here today. So following on from the HSE Pressure Ulcer to Zero initiative that they brought out a couple of years ago, they were actually get pressure ulcers down by 73% in the acute care settings, so in the likes of hospitals and things like that. The financial cost of pressure ulcers is deemed to be huge. It's estimated, because no one knows the true cost of it, but on average for someone with a grade 4 pressure ulcer, so that's pressure ulcer that's quite involved, it can cost anywhere from 70,000 to 119,000 to successfully treat one patient. And on average, it's estimated to cost 250 million every single year to treat pressure ulcers across all care settings in Ireland. So you can see why there's a lot of research being put into this and to help prevent it, because there's such a financial cost underlying it all. But there's a human cost as well, I suppose, that really should be to the forefront and just not be forgotten. And I suppose some of the things that can be experienced and what have been reported by people is that they can experience pain and discomfort. Now, not everyone will have pain associated with a pressure ulcer, depending on their level of sensation. There can be an increased risk of infection associated with pressure ulcer developing, decreased quality of life, decreased independence. A lot of people end up kind of, I suppose, on bed rest or changing their wheelchairs or whatever it may be, and they're just not able to get out and about as much as before. Some people report a lot of loneliness related to it, and that's while they're undergoing treatment and kind of stuck at home. And some people get very depressed and have low self-esteem. There can be embarrassment if there's odour associated with the ulcer, because some of them can be quite odorous. And for those who tend to get autonomic dysreflexia, so with your spinal cord injury, generally T6 or above, I know any of you that would have attended the last session with Paula, she would have probably mentioned it. But pressure ulcers can basically contribute to autonomic dysreflexia as well. Prolonged hospitalisation or bed rest. We did have a client of ours here at Crann who was 7 months on bed rest in total about 2 years ago, and 3 months of those were spent in hospitals trying to get the ulcer treated. So you can see it has a huge impact on someone's quality of life. People can lose limbs if they're left untreated, or if it deteriorates further, and even death and sepsis can be related to a pressure ulcer, as with the infection that's mentioned there. So the biggest thing really with it is not to wait until you get one, but to react beforehand. A lot of them are preventable in up to 95% of cases. Anyone of any age can get a pressure ulcer. It doesn't mean you've done anything wrong if you have one. They're very common, but I suppose it's just to have the knowledge behind it to try and help to prevent it, and awareness is key. So just differentiating then amongst your skin breakdown. So the pressure ulcers, as we've said, tend to happen over a bony prominence or under a medical device. Some people will get them while in hospital if they've got like nasal prongs on their nose, for oxygen, and that can just kind of affect your septum there. Or you might have an IV cannula in, or there might be something like a cast or something like that. So it isn't always just the way you're seated. And generally it's from pressure or shear. Then two other things, and really they're just mentioned just so you're aware of them, that they are different. They're not a pressure ulcer in themselves, but just as if they're very common as well. And it's incontinence associated dermatitis and intertriginous dermatitis. So we'll just show you pictures of those there now. So this one, generally the intertriginous dermatitis, it's just for you to be aware of. It's an inflammatory condition of skin folds. So for women, under the breasts, along under the buttocks, in between the buttocks, anywhere where there's an overlap of skin. And some people who might have additional skin folds, they might have it in between their skin folds. And it's just usually induced or aggravated by heat or moisture or maceration. Maceration just basically means that skin is saturated with some sort of water or fluid, by friction from things rubbing off each other, or a lack of air circulating. The other one then, just to be aware of, and this is different to a pressure ulcer again, is incontinence associated dermatitis. So a lot of people, if they're in incontinence pads, or if you've been unwell and had a bad gastro or diarrhea or something like that, or if there's a constant leak of urine, can develop this. So it can be quite inflamed. So these two here are not a pressure ulcer, but it's just to be aware that they can be misseen as that. So how does it develop? So we've mentioned it already. It's pressure and shear are the leading cause. So if you're mobile, you're at greater risk of pressure because you can't relieve pressure over the bony prominences. And activity and your level of activity and your level of mobility are your highest predictors of risk. So these are your factors that cause an individual to be exposed to pressure and shear, and people with spinal injuries are at high risk of pressure ulcer development, basically because if you are, depending on where your level of your injury is, whether you're able to move, kind of like adjust your position or not, some people are, some people aren't. And if there's constant pressure over a bony prominence, that's why you're at risk of pressure and also at risk of shear. And so that's just why you're at more risk of pressure ulcer development through no fault of your own. So how they develop, I should say some of the following slides, like this one, are a little bit gruesome. So if anyone's a bit squeamish, I do apologise. There are ones from the National Pressure Ulcer Advisory Committee. So they're kind of out there in all the guidelines. They're the most common ones that you'll see around. So basically, a pressure ulcer develops from underneath, so from inside out. So some people think, oh, there's a little tiny pinprick on my skin and it's a little bit red, and it's not, the redness isn't going away, but sure, that's fine, it's only tiny. But you don't know what's going on underneath. It's a bit like the iceberg effect here that you can see. So there's an element of where there's something above the water, but there's something huge going on underneath. So if you think of an iceberg with a pressure ulcer, you don't really know what's going on in the other layers of the skin. So it's just to be mindful of that. So if you think of, this is how pressure over a bony prominence occurs. I'm not sure if you can see my, my mouse there, but here you have bone, So this is bone, soft tissue, blood vessels, and skin layers. And if you have pressure, so say this is like example of your pelvis or your hip while lying on your side, and that is pinching down and leaning on your skin over a hard surface like a mattress, or like say if you're on a trolley in a hospital, you'd be more at risk again. This just basically pinches. And if you think of a garden hose where that's pinched and the water behind it can't flow, that's the same with blood, your blood flow. So if you pinch your blood vessels here and they're pinched off and the blood can't flow, that reduces the circulation to that area. So that's what can cause damage. Again, this is a very similar kind of explanation. So you have someone lying here, there's the back of their head, their shoulders, their elbows, their sacrum here, their coccyx, the base of the spine, or their ankles or their heels are touching. Anything that's in contact with the surface. You have your weight of your body down on top of that, and that's pinching down amongst those layers. So it's basically compressing those layers, and you've pressure underneath from the surface. So it's the combination of the weight above of your body and the pressure underneath from the mattress. And that's what's causing that pressure to your skin and reducing the blood flow. So common areas of skin breakdown. So it depends really on what way you're lying or sitting as to where the pressure will be applied. So, and it's different from children to adults. So these are based on adults only really at the moment. So here you'll see someone that is lying, the one over here on the left, they're lying on their side. So it's the side of the head, their shoulder, here all around, they just have other words, but basically it's all around the side of your hip, down the side of your body, your knee, the inside of the other knee, and then down here by the ankle. If you're lying on your back, it's different again. It's the back of your head. You might have the rim of the ear. They're very popular, or it's very prevalent or common to get them on your ears actually, especially if someone is in bed quite a lot, or if they're bedbound or quite incapacitated after being unwell, or if they're hospitalized, the ears tend to take a bit of a bashing. The back of your shoulder, your elbow, the back of your sacrum here again, where your coccyx is, just at the base of the spine, and the back of the heel. When you're in a sitting position, it changes again. It's your shoulder blades, whatever is in contact with the surface. So if you think of your chair, whether that be a wheelchair or the chair you're sitting on during the day, it's where you're in contact. So shoulder blades, again, the sacrum and the coccyx, your hips, the back of the knee, and which tends to be forgotten actually quite a lot when people are checking their skin. They forget about the back of the knee, the back of the heel, and it could potentially be the ankle as well, depending on where your foot plates and things are. So you can see there again, the tailbone really is mentioned quite a lot in all of them. So if you're lying on your back, if you're sitting in a chair, it's the tailbone here, the sacrum, tends to kind of have a lot of pressure. So just be mindful of that. So risk factors that we've mentioned already, the biggest ones are immobility and inactivity. If you have paralysis or sensory loss and you're unable to sense that there's pressure or pain there, excessive moisture it's not directly a cause by itself. If you only have moisture and nothing else, you just have skin breakdown, over time. But moisture in combination with pressure or shear can lead to pressure ulcer development, because moisture, if you think of moisture, it basically causes skin to be fragile. So if someone's incontinent of their bladder or their bowel, if they're perspiring a lot and that area of skin isn't able to be dried, or if the person is showering or bathing and they're not able to dry themselves properly after, anything that leaves moisture on the skin in combination with those other factors can just lead to pressure ulcer development as well. Another thing that can happen is you can get muscle atrophies, particularly if someone's hospitalized for quite a long time, if they're in bed quite a lot, or post-spinal injury. Again, some people would notice that when they're no longer able to use a particular limb, that muscle mass will start to kind of atrophy and shrink. And when it shrinks, it reduces the padding over the bony prominence, so over the hips or the knees or the buttocks or wherever it may be, that shrinking can lead to additional pressure. Nutrition, there's a risk of malnutrition can be associated with it. So if someone is overweight or underweight, they can be contributing factors. And if you've altered circulation or blood supply, delayed wound healing, and pre-existing or a history of pressure ulcers. So if you currently have a pressure ulcer, or if you've had one in the past, you're more likely to develop them again in the future. And I suppose that's really just down to the fact that those risk factors are there anyway. So your risk factors of people with spinal injuries, the reason you're at such a high risk of pressure ulcer development, and that's why this talk is going on, is just, I suppose, to get it in your mindset that it's not anything you're doing right or doing wrong. It's just to get an awareness out there that, I suppose, you are more at risk, and to put, I suppose, surveillance in place to make sure you check your skin on a daily basis. There's no blame at all from anyone. So pressure damage is from prolonged sitting, burning, freezing, or pressure that might go unnoticed. So because of lack of sensation or whatever it may be, you may not notice that there's burning. I've had reports of people saying that they've burnt, feet off radiators, or they might drop hot liquid on their laps and have not, had one sensed it. And it's similar with freezing as well in cold environments. Damage from pressure, moisture, friction, shear, and swelling are also contributing factors. And I've said it before, it's activity and mobility are your highest predictors of risk. So the more immobile you are, and I suppose the level of your level of activity will contribute to whether you're at risk of pressure ulcer development. And this thing here, this graph really is just reiterating what's been said already. So it's called the hierarchy of risk, and it's by this guy, Moore et al., and a group of people put this together. And while it's just kind of reiterating what's been said, you can see that that's your prime cause of a pressure ulcer is pressure and shear, and under that is immobility. So that's, if you have a combo of all of those, that puts you at greater risk. And if you add in the bottom layer here with your age, if you have incontinence, malnutrition, and your general health, if that's poor, it just increases your risk again. So just going back to the skin, and this is just before we go through the different, I suppose, grades of pressure ulcer, and the idea behind showing you these is just so that you can notice if this is happening in your own skin and to kind of put plans in place sooner rather than later. So the skin is the largest organ of the body. It's as important as your heart and your lungs. A lot of people will overthink the skin. They wouldn't see it as an organ at all. But without the skin, we would be exposed to a huge amount of, I suppose, bacteria and germs, as we can see with COVID at the moment. It's all about the hand washing, keeping your hands clean, keeping your skin intact, things like that. So your skin is a barrier, protects your body from harmful things like moisture, the cold, sun, UV rays, bacteria, and toxic substances. It helps to regulate your body temperature. It's a store for water, fat, and metabolic products. It helps with your vitamin D production when you're exposed to sun. It's involved in wound healing, obviously, and then it's related to your sensation, whether you've touch, pain, pressure, or you can sense temperature. And your three main layers is more than that. There's double those amount of layers, but these are your three main layers. So this is your epidermis. The second one here is your dermis, and this is your hypodermis. So if you just kind of think, look, there's three layers of skin, and it's just to kind of show you the different levels of the involvement of each grade of pressure ulcer. So with classifications, this is your staging, and this is known throughout Europe. It's under the European and the National Pressure Ulcer Advisory Committee, and they put these guidelines out on kind of a yearly or every 2 yearly basis to all the hospitals and anyone involved in that. And so the idea behind it is that you develop your I suppose your care within the hospital for prevention based on these. So you've stage 1, stage 2, stage 3, and stage 4. So the first stage is non-blanching erythema. So there's a lot of writing here. It's probably too much for people to kind of take in. But the whole thing is with non-blanching erythema is that there's an area of redness over a bony prominence. So, and the redness doesn't go away. There might be pain there. It might be firm. It could be soft and a kind of a boggy sensation. It can be warmer or cooler compared to the other tissues. So for some people who might get an area of non-blanching erythema, they could have the surrounding skin might be cooler or might be warmer. So there's just a difference in the feel of the skin. In people who are darkly pigmented, it can be more difficult to notice this stage and it can be overlooked. So it's just to be mindful of that. So for non-blanching erythema, it's just here up in the top layer of the skin, and you can see that it hasn't gone back down into the other layers. This is what it can look at like in the coccyx area, and the idea there is just to be mindful of it. So this is probably more likely related to pressure, or could be with shear as well. And this area of redness here, if you were to press on that area of redness won't disappear, and that's a sign that there's damage being done to the skin already. That stage then can move on to the next stage, which is category 2, and there's partial thickness skin loss. So basically all that means is that the skin on the first stage here is still intact. None of the skin is broken down. And on the next stage then there's partial thickness loss. So basically part of that skin is after getting damaged. And you can see here it's just starting to embed itself down a little bit deeper. So this is what the skin might look on the outside. And this is kind of back to the iceberg effect, where you look at that and you kind of think, oh, there's not much else going on. But deeper down, the damage is already being done. Category 3 is full thickness skin loss. So basically, the subcutaneous fat, which is kind of your top layer, might be visible and exposed, but the deeper down layers of bone and tendon and muscle are not exposed yet. There could be slough, which is kind of like green exudate. Can be kind of a different colour, kind of whitish colour as well, depending on whether there's infection there or not. And that may or may not be present. The bridge of the nose, the ear, the back of the head and the ankle do not have subcutaneous tissue, and so category 3 ulcers can be shallow there. So you might notice that you go from a pretty intact skin to unintact, kind of like broken down skin area quite quickly in those areas, just because there aren't the layers as deep as other areas of the body. And here you can see it's gone quite down. So even from the top here, there's an exposure. It's hard to tell now with this picture, but this area here is damaged skin, and this is the exposed area in the middle, and that's just representative there. So you can see it's gone from literally maybe a grade 1, grade 2 downwards, and it moves down quite relatively fast for people, depending. The thing with pressure ulcers is that they'll move through and deteriorate further. So if pressure or shear continue to be applied to the skin, they'll deteriorate further unless something's put in place to reduce or remove those risk factors. The next category is category 4. This is full thickness tissue loss. So basically the bone, tendon and muscle in the underneath layers are now exposed. You can have slough or eschar. Eschar is basically just dead tissue, and that can be present in some parts of the wound bed. The depth of pressure, the category 4 pressure ulcers vary by depending on your location of your body. So again, the bridge of the nose, the ear, the back of the head and the ankle, because they don't have a lot of subcutaneous tissue, those ulcers can again be quite shallow. So you can imagine if you have something on your ear and the back of your head, there isn't a huge amount of depth to go through to before you hit bone, so they can kind of be exposed quite quickly. And that again is, you can see here, the same again. This time you can almost see the tunneling. It's a lot more evident. You can look down into the wound and see that it's quite open. And these are the wounds now that are going to take that bit longer to heal, because they're after coming down here and their bone, underneath is now exposed. You can get ulcers that when you first see someone with the pressure ulcer, and they might be unstageable. So the wound care nurse or the vascular nurse might be unable to tell what level or stage of pressure ulcer there is. There may be that there's too much slough, so it can be yellow, tan, grey, green and brown. As I mentioned, there's different kind of colours it can present with. The dead tissue can be tan, brown or black in the wound bed, and if there's so much of that there that you can't see past it, you may have to get that wound debrided or cleaned out first before you're able to tell what level or what staging it's at. So you can see here it's unstageable because all this dead tissue is still in the wound bed here. So if you were looking at that, you wouldn't know what's going on underneath that. So basically it's unstageable because you can't tell what layers are involved. Then you can have someone who presents with a deep tissue injury. They may present as if they have a pressure ulcer as well. It can lead to one. You can get a purple and maroon area. Basically it's just a blood-filled blister. And the area around it preceding that can be firm or mushy or boggy or warmer or cooler, very similar to the other ones, and basically it's from an injury. So here you can see it's quite a large area of bruising on this person's heel, and so there it goes down through the layers. So the skin is still intact throughout, but there's a lot of area damage. So if there was pressure applied to that area of skin would be quite at risk of pressure ulcer development. So this pressure, or this scale here, just shows you quickly the different staging. So you can see you go from 1, 2, 3 and 4, and you can become quite involved. So if you have an area of pressure here, you'd hope that you'd catch it at this stage so that you can put your preventative strategies in place, remove the pressure, remove the shear. look at the person's nutrition, at their continence, and see if there's anything you can help in those areas so that you remove as many risks as possible for further development. If it goes on that the pressure or the shear and shear, both of them together, or just the pressure itself is still applied, you're going to have a continuous change in the pressure ulcer and for it to deteriorate. Some people have an unavoidable pressure ulcer, and basically all that means is that you do everything correctly, you do all your preventative measures, it's all in place, and the person still develops a pressure ulcer. So that can happen. So I suppose this is the slide really for a lot of you to kind of, I suppose, even if you haven't taken a lot from the other information, and I know there's quite a lot being bombarded at once, even if you just look at this slide, this is the one really, I suppose, for you to take home and for what you'd be looking at. So when you do your skin assessment on a daily basis, this is what you'd be looking for. So is there any redness or inflammation of your skin? Are any areas of skin hotter or colder than the surrounding tissue? Some people, dependent on where it is, whether it's above or below your level of injury, you might notice that there's pain. There could be a change in texture of the skin. Not only it might be hot and cold, but it also might feel hard or a boggy feeling where there's a bit of give in it and it doesn't feel quite right. Some people say when they have a pressure ulcer that there's an area of numbness, and that's kind of to do with the level of involvement as well in the skin layers. There can be discoloration, and some people report itching. So they're the main things I suppose to look out for. This video here is from the NHS, so they've done quite a lot of work on this. It was, I think, an occupational therapist was involved in this. I put it in because I think it's just a nice one to hear people's stories of how a pressure ulcer developed. So I'll just pop that on there now.
The only way I can describe it is though I was sat on top of a hot plate on the cooker.
It was horrific.
I get so angry because I'm in bed for so many hours.
It's a very large cavity and it can be fatal.
The other stupid thing that I didn't tell anybody.
Pressure ulcers, often known as bed sores, can be very serious. The area may be very red and inflamed.
I couldn't believe it when I saw it, you know. It looked like a horrible, overripe tomato on my buttocks.
A really nasty pressure ulcer can be a deep cavity. You may be able to see muscle or bone or tendon. The wound may bleed. The wound may weep fluid. They can be very foul smelling, like rotting flesh. The worst thing that can happen is complications causing death.
The pain was terrible.
People don't realise how they do impact on lives.
I couldn't sleep, no sleep, day and night, and at times I felt reduced to tears.
Awareness is the key.
Being the silly old twit that I am, I didn't complain till my wife saw me wincing.
If we're not able to look after our own skin, then somebody else needs to be doing it for us. They need to be looking out for any signs of discoloration, numbness, pain, itching, heat, or hardness.
I got one right on the coccyx at the bottom of the spine.
The most common area for a pressure ulcer to develop is on bony prominences, the bottom, the ankle bone, the heel, the base of the spine, bony shoulders, elbows.
I'm on dialysis 3 days a week, 4 hours at a stretch. You're bound to sit still.
Pressure ulcers can happen to anybody at any age. We see a lot of patients that are elderly, disabled, pregnant women during labour. Young children can get pressure ulcers, anybody that's got poor mobility.
The reason I'm sitting all the time is I've got a spinal problem. I use my chair to get me up on my feet and stand, if it's only 2 or 3 minutes.
The 5 key messages to prevent pressure ulcers are to look at the surface that you sit on and that you sleep on at night. It might be that you need a special cushion or a special mattress that helps redistribute the pressure evenly. Always check your skin. Skin inspection is so important in picking up skin changes early on. Always keep moving, keep mobile. The ideal for somebody at home is to move every 2 hours. Incontinence and increased moisture. Any moisture against the skin will make that skin more fragile and vulnerable to breaking down. And then nutrition and hydration. A good healthy diet is very important in preventing pressure ulcers. So SSKIN is S and then skin.
The worst thing I did was put up with it. I should have gone long before I did.
The message that we want people to take away is help us to help you to prevent pressure ulcers.
I'm hoping we're going to see the end of them, you know. I'm determined.
Now, just moving on from there, you can see that just the importance of telling someone if you do notice anything on, and checking your skin as well, and getting help early. There's no, I suppose, you know, there's nothing to be ashamed of if you do develop a pressure ulcer. The main thing is to try and get help early and so that preventative measures can be put in place and strategies put in place to help remove pressure and shear, and look at, I suppose, as that video mentioned, to look at your continence and your nutrition and your hydration and things like that. Other possible treatments of pressure ulcers, in general, your first stop is wound care. So there'll be dressings, assessments and treatment of any infection. An infected wound won't heal. There'll be delayed healing, so some of them may need to be cleansed and debrided by a vascular surgeon or by a surgeon. A lot of people will get referred to a wound care or tissue viability nurse specialist in the hospital, or some get referred to a vascular nurse specialist. The public health nurses are also great for if it's been reviewed or it needs ongoing dressings. A lot of you might have noticed that you've been referred to your public health nurse. Some people need surgery, some people need grafting. It just depends how involved things are. In general, people who have quite involved pressure ulcers generally have nutritional review. So if it's something that is ongoing for yourself and you haven't been, I would kind of advocate that you get referred to your community dietitian as soon as possible. Your GP can do that for you. Or if you're in contact with the nurse specialist in the hospital, ask them to refer you to the hospital dietitian if they can do so. Sometimes supplementation with zinc and different things like that, they've got a lot of pre-made drinks and stuff that have a lot of minerals and vitamins in them that can help as well. Repositioning and early mobilization is part of your treatment plan, and involvement of an occupational therapist. So they generally look at the support surfaces where you sit during the day, looking at your chair, looking at your cushions that you're using at home. Do you need a pressure relieving mattress? If there isn't one in place already, you might need a profiling bed added in just to help you kind of elevate during the day, and change your position, and pressure relieving boots. The other thing you may need to look at is that you might need additional care in the home if you don't already have it, and that you might need someone to come in and check your skin for you. So how do I prevent pressure ulcer? As I mentioned already, SSKIN. So you check, inspect and react to red. So there's a little video I'm going to show you in a minute how to do that. So that's your starting point. You look at your surface. Is it the best surface it can be to sit and to sleep on? We sleep for a significant part of our day, so it's just important to note that it's not just where you sit during the day, it's also where you sleep at night. You need to look at that, the pillow that you lie on, the mattress that you sleep on. Keep moving in so much as possible. I know that's not possible for some people, but just try and incorporate some way of changing your position throughout the day. If you can't do it yourself, get your PA or someone who your partner or someone to come and help you change your position regularly throughout the day. That video recommends 2 hourly. And then incontinence away. So if you are in pads and you've noticed that there's a lot of leaking, or if you're having issues with ongoing diarrhea or anything like that, then again, you need to look at that. And nutrition and hydration is essential for prevention of pressure ulcers, and also for healing of them as well. So this little video is only a few seconds long. It basically shows you how to check your skin, and it's looking at the erythema. So this is your non-blanching erythema is what you'll be looking out for. So you press and hold, count to 5, and then release. And when you release, that area should then go from white, it should blanch and go back again. So we'll just do that again, just to show you again, because it's so important. So you literally press and hold, and the area should blanch. So you can't quite see it under her finger there, but that will go white. And then when you release, the whiteness should then reperfuse and the blood flow should come back. So with non-blanching erythema, what would happen there is that would stay red. I'm going to let me move. There we go. And so where to now? So you've noticed that you've an area of non-blanching erythema. So the first thing to do is look at where you're sitting and where you're sleeping, remove the pressure, and look at your positioning during the day. Are you sitting in a kind of a semi-reclined position quite a lot? Elevated on a pillow. While it's good for you to be upright, it also increases your risk of shear. So try not to stay kind of at that 30-degree angle for too long, because the shear between your pelvis and your skin will obviously be increased. The first point of contact is your GP. So I would always advise that anyone who has, if they're not happy with their GP, that they try and find someone that they trust and that will react when you tell them you have a problem. Your GP then will do a review and an onward referral to either your public health nurse. You might notice that you go to your public health nurse first and they might be happy to dress something, especially if it's kind of a grade 1, grade 2, they'd be happy to manage that initially. For anything kind of more involved, they tend to refer on to the local dressing clinic where there's nurses specialising in dressing all the time if you need a lot of dressings on an ongoing basis, or they might send you on to a tissue viability nurse, a vascular nurse, or a consultant vascular surgeon, depending on what the level of involvement and the healing as well. And then it's kind of intertwined in that they can send you back then to your PHN again, just for ongoing dressings if that's needed. So the main thing really is, I suppose, this information is part of a bigger program that we do about pressure ulcer prevention, but I hope it's given you a good indication as to how to look after your skin. There is more information available about how to do that on a daily basis and how you incorporate that into your routine and what you're looking for. The main thing, I'll just pop back here, is if you look at SSKIN, you basically check and inspect your skin on a daily basis and always react to red. So if you've non-blanching erythema and you've redness that isn't blanching, you need to react to that. Don't leave it for a day, don't leave it for 2 days. You really need to be reacting to that straight away. Relieve the pressure, change your position, and check it again in about 15 minutes. And if you find that isn't blanching again and remains red, then you need to really be looking for help at that stage to try and catch that early so it doesn't develop further. Okay.
Thank you very much, Eimear.
No
we have a couple of questions.
Stop sharing there, sure. Yeah.
One person asked, I don't know if there's a proper answer to this. What's the fastest way to heal a pressure sore? Is there a fast way?
I suppose if you look at everything holistically, like some people will do everything right and their healing still won't be great. So if you've poor circulation and decreased sensation to an area, you're going to have a longer time period for healing. If you look at your nutrition, make sure it's adequate. You might need to get a dietitian involved. Look at your seating, what is the support surface that you're on during the day and in the evening sufficient. You may think that you're relieving pressure by changing position, but you might actually be unaware that the surface that you're on is actually too hard and exacerbating that pressure. So I would say if an ulcer isn't healing or it's taking ages to heal, you really need to get that reviewed. Some people might have been referred to their PHNs. In general, the public health nurses are great for it's their bread and butter. They're doing dressings morning, noon and night. But if you're going to someone, whether it be a GP or a public health nurse, and you're not happy and it's not healing, I would ask for an onward referral to someone for tissue viability and get that seen so they can do a holistic review.
Yeah, that makes it's not really the fast isn't really a thing.
Yeah. And if you have infection there as well, I suppose that's the other thing as well. If a pressure ulcer gets infected, that will delay healing as well. An infected pressure ulcer will not heal. It has you to get rid of the infection first and then heal then. And the other thing with pressure ulcers, which I didn't mention, is that a pressure ulcer, it develops from underneath up. It also heals from underneath up as well. So it can be healing the lower layers and coming through and then going up to the surface. So the surface bit would be the last part to kind of close in and heal. Yeah.
I just have a question from a service user there. A vascular consultant she asked specifically for outpatients from the NRH. Would there be particular vascular consultants that would specialise in pressure sores or pressure wounds?
I can't answer for Dublin now. I'm only familiar with Cork. I know in the Mercy in Cork, Mr. McGreal does an awful lot of work with pressure ulcers, and he has a vascular nurse and he has a tissue viability nurse that work under him. They do a huge amount of pressure ulcers. I couldn't tell you outside of Cork. I'm in the Cork zone, unfortunately, but yeah, we can look at it.
If that person wanted to contact any of us in spinal injuries, we can refer them to the NRH, and they'd be the best people to the outpatient liaison service. They'd be the best people to refer on to vascular surgeons, especially in the Dublin area or anywhere around the country. They'd be the ones that would know. I just have one more specific question for you. Somebody has heard about maggot therapy for pressure wounds. Is that something that's done in Ireland?
I actually don't know whether it's done locally. I don't know, being honest. It is something you'll see in the literature. I know in the NHS they're using leeches quite a lot, more so than maggots. I actually only saw a programme the other evening about a leech farm, and they're farming them and they use them for post-operative healing, and because they just increase the circulation. That's the whole thing about it. Not sure about maggots. I've heard of the leeches, and the idea is that they basically adhere to the skin, and they, because of the sucking action, they increase the circulation, and that's the idea of it. Healing.
If you don't look at it, if you don't know what's happened, then yeah. I think on that note we'll end. Thanks a million, Eimear. Really appreciate it.